So again, welcome. This is a presentation entitled Culturally Responsive and Socially Distanced Suicide Prevention, Safety Planning, and Other Resources in Pandemic Times. A disclaimer that the views that I'm about to share today do not necessarily represent the Center for Mental Health Services or the Substance Abuse and Mental Health Services Administration, nor the U.S. Department of Health and Human Services. If you might be new to the Training and Technical Transfer Centers of SAMHSA, I am thrilled to share with you that we, as the Pacific Southwest Mental Health TTC, are one of 10 centers across the nation, and there are 2 centers that are specific to communities. There is the American Indian and Alaska Native MHTTC, as well as the Hispanic Latino MHTTC. We represent Region 9, and we are the green region that you can see in the Southwest. We include California, Arizona, Nevada, Hawaii, and the Pacific Islands. In addition to the mental health TTC, there is also an addiction TTC and a prevention TTC. If you're connecting to us from outside of Region 9 and you would like to be connected to your local TTC, please let us know. We'd be happy to help make that connection for you. So our role, we offer a collaborative MHTTC model in order to provide training, technical assistance, and resource dissemination that supports the mental health workforce to adopt and effectively implement evidence-based practices across the mental health continuum of care. Our goal is to promote evidence-based, culturally appropriate mental health prevention, treatment, and recovery strategies so that providers and practitioners can start, strengthen, and sustain them effectively. We offer a variety of services through the Pacific Southwest MHTTC. All of our services are no cost, and they include training, technical assistance, and resources. And without further ado, I will go ahead and get started. So as I shared, my name is Eliana Ramirez. I am a social worker by profession. I have spent many years addressing suicide prevention, and suicide postvention. Most recently, I worked in the Veterans Affairs Hospital where I worked on suicide prevention with lesbian, gay, bisexual, transgender, and queer-identified veterans, otherwise referred to as LGBTQ. I've also done suicide prevention with Donatham youth on the Donatham Reservation in southwestern Arizona, as well as incarcerated women in Santa Clara County, California, and women injection drug users in New York City. I have conducted suicide prevention on an individual level through counseling, as well as at a family systems level. And I've done suicide prevention with groups, including LGBT veterans at VA Palo Alto. And I have also written policy and protocol for clinical groups like the War-Related Illness and Injury Study Center. And then finally, I've created college-level courses for peer support suicide prevention among veteran students. These are typically reentry students. My interest in suicide prevention and postvention is personal and professional. I happen to be, I identify as a queer mixed-race Chicana, and many of the communities from which I am a part experience higher rates of suicide. And so, again, this is something that I take very close to heart, as I know it's probably true for many of us who are on this call as well. So with that, I'd like to give just a general overview of today's presentation. We're going to start off with some welcomes and getting to know one another a bit. And then I'm going to start to talk a little bit about suicide in pandemic times, and specifically this current pandemic of COVID-19. Then we're going to talk about some of the COVID-19 stressors and really dive into what it means to provide evidence-based practices for suicide prevention over telehealth in a socially distanced environment. We're going to talk about evidence-based practices like safety plans and means restriction. We're also going to talk about community-defined evidence so that we can loop in a particular lens on culturally responsive suicide prevention. And we're going to end by talking about a couple of communities in particular that have disproportionate rates of suicidality. These include veterans, LGBTQ people, Latina youth, Native American communities, and middle-aged older men. A bit of housekeeping, otherwise known as presentation participation guidelines. If you would please place any comments that you have in the comment box, and I welcome everyone who's continuing to introduce themselves in the comment box. It really is great to see so many of you from all over the country. I'm going to ask that if you have questions that you actually place them in the middle box that is entitled questions. This way, my colleague Angela it'll be easier for her to track those questions as we move through the presentation. I ask that people please use I statements in the comment box and avoid making comments that are stigmatizing or otherwise injurious toward other people. I just want to acknowledge that many of us are kind of maxed out right now. We're all surviving a global pandemic. Many of us are doing direct practice and helping support our clients who are themselves experiencing oftentimes increased mental health challenges due to the pandemic. And many of us are also people of color and are experiencing higher levels of stress also based on not just the racial trauma that has been happening over the course of our lifetimes, but the organizing, anti-racism organizing that's been happening in society as well, is resulting in increased stress as well for folks. So I just especially want to invite people to try and engage in the comment box with a particular attention to how our comments might affect other people. This is a tricky one because many of us are working from home where we might have children or dogs or cats or many other things that are going on in our lives. But to the extent possible, I would like to invite you to please try to avoid multitasking during this presentation. It can be difficult content, admittedly, and the more that we're able to really focus here on this presentation rather than sending text messages and emails, I think that it'll be a better outcome for everyone to the extent we're able to do that. And then finally, as I mentioned, COVID-19 and suicide are painful topics. Self-care is essential. I do invite you to please access support as needed, and this is the caveat that, of course, if during this presentation you feel like you need to get some support immediately, please do reach out. I've provided just two options. There are many out there, but the two that I've provided here are the National Suicide Crisis Line, and you can both call and send a text message, and there's also the COVID-19 Crisis Counselors. Again, you can call them or send a text message. And again, for anyone who's just joining us, please do feel free to download the presentation from the bottom left-hand box that's entitled Handouts, where you can find these numbers listed there again. So I want to start off here with these two images. Both of them are from social media. In fact, I saw both of them on Facebook. The first, in case it's hard for you to see, the first one says, even in the middle of pandemics and protests, Black creativity is still our saving grace. And on the right-hand side are images of Native American women who are dressed in traditional regalia. On the right-hand side, and you can see that they have the emblems of different branches of the U.S. military on their backs. And in the picture on the top right-hand corner are, they're doing the color guard. So they're presentation of flags for the U.S. military as well as for the United States government. And that image on the right is a post about suicide prevention and PTSD among Native American veterans. I start off with these two images because Black, Indigenous, and other people of color are disproportionately affected by COVID-19 and racial violence, as I mentioned previously, as well as suicide. But it's important to point out that Black, Indigenous, people of color, and LGBTQ people and veterans also have developed resilience to survive a variety of different types of social injustice and even plagues. And I think about most recent examples might be LGBTQ community and the HIV/AIDS pandemic. Many of us in our training programs did not include the histories of resilience and strength that these communities developed to survive the different types of injustices that they experienced and plagues that they've lived through. But many of those strengths and resiliencies can be very, very helpful not only to their own communities, but to communities beyond themselves. And so I just want to start off by saying that while I'm going to be talking about the disproportionate impacts of COVID-19 as well as suicide on diverse communities, there are also significant strengths and resiliencies that we can draw from. Just one example of this is the concept of camp. Camp is a cultural form of humor and strength and resilience within the LGBTQ community. If you're not familiar with it, it is a way of disrupting the power dynamic of a heteronormative society by making fun of parts of heteronormativity that are otherwise difficult or create challenges for LGBTQ people. So one example that's specific to a pandemic would be with the HIV/AIDS epidemic in the mid-'80s. There were significant numbers of soldiers and other service members who were becoming infected with HIV/AIDS. And at the Oak Knoll Naval Base in Oakland, California, the 9th floor became what would now be called the HIV/AIDS ward. And the people who were on this ward experienced significant discrimination from doctors and orderlies who would quote the Bible to them and damn them to hell, as well as refuse to provide them treatment or leave their food outside of their rooms because they didn't want to become infected. We saw the same things happening in the civilian society. Well, the people on this ward started to kind of push back with camp. And so they would do things like when somebody would call their ward, they would answer the phone and they would say, "AIDS are us." And it was a joke, which was to kind of shock people and take them out of that dynamic of pushing these people who are living with HIV/AIDS to the boundaries of society. Additionally, they started to refer to their ward as the penthouse in the sky, because their windows were the only windows from which the hospital at night you could see the San Francisco skyline of the lights. So again, camp is a way to deal with a difficult situation with humor, with strength, and kind of disrupt the power dynamic that people see. So with those two brief pieces there, I want to go ahead and invite people to answer a couple of questions so we can get to know one another. The first question is, what type of job do you do? Are you a social worker, psychologist, marriage and family therapist, a peer specialist, a school mental health provider, program administrator, or other? And I invite you to go ahead and type it in. Wonderful. I'm seeing, gosh, a great diversity of professional backgrounds here. I'm seeing social workers and psychologists, marriage and family therapist. I see TK through 12 grade school counselor, counselor for at-risk youth, psychologist, mental health counselor, program manager. Wonderful. So we are really seeing a wide diversity of people who are connecting here from a variety of backgrounds. I really enjoy working with interdisciplinary audiences, and I think that brings up a great diversity of strengths and knowledge bases. And so I invite you throughout this presentation to share in the comments box any cultural strengths or resiliencies that you're aware of with the clients that you work with, and any distinct strengths that come from your discipline, whichever profession it is that you might work from. And I'm especially welcoming of feedback from our peer specialists who might be joining us today. I think that peer specialists have a unique perspective that can especially be helpful in times of pandemic crisis like we're living in. Many of us who come from licensed clinical backgrounds were taught that we had to have a very clear division between the personal and professional and private. And for many of us, working from home is challenging that divide. Additionally, many of us are having to deal with the stress that we're living through this pandemic while we're also being present to the clients that we serve who are also dealing with the stress, of course, of living through the pandemic. And I think peer specialists, because their training involves being thoughtful about how to use their personal experience in an appropriate way with clients, could really teach a lot to the rest of us who come from psychology or marriage and family therapy or psychologist backgrounds, social workers, who are maybe not trained as much about how we can use appropriate use of self. So with that, thank you very much. We'll move on to the next question. Does your agency have a suicide prevention protocol for the COVID-19 pandemic? For example, a plan for who conducts suicide assessments, which assessment tools to use, and what to do if suicide risk is identified? And I see the answers coming in here. Thank you. I'm seeing people are answering yes, no, I don't know, not applicable. Okay, so far it looks like we've got 56% who are saying yes, about 30% are saying no, 8% I don't know, 9% not applicable. Okay, thank you very much. So we will keep moving on here. So I really want to thank the over 100 people who answered questions that we had sent out with our registration email. I was very interested to know a little bit about what your learning needs are and what you're most interested in getting from this presentation. And so I'm just going to share back with you what I learned from your feedback. So first of all, about half of the people who responded, about 37%, said that they've received a little bit of training on suicide prevention. 40% said they received a moderate amount of training. 17% had said that they had received a lot of training on suicide prevention, evidence-based practices, and about 5% said they had not received any training. In terms of how prepared respondents feel to teach clients or mental health consumers skills they can use instead of acting on suicidal thoughts, 64% said that they felt somewhat prepared. About 20% said they felt very prepared, and about 16% said they did not feel prepared. The next question, have you worked with clients or mental health consumers experiencing suicidal thoughts or behaviors? And 83% said that they had, 11% said no, and 6% said they were not sure. In terms of the types of information that people were most interested in receiving from this training, there was significant interest in how to conduct assessments, suicide assessments, especially over telehealth, how to manage suicidal crises over telehealth, strategies to avoid engaging in suicidal behavior, COVID-19 and suicidal risk, culturally responsive suicide prevention, and the very end, and this was very interesting to me, the topic of least interest was means restriction. But as you'll see in subsequent slides, people are very interested in learning evidence-based practices for suicide prevention. And means restriction is one of the most important evidence-based practices that is available. And it's what we might consider to be kind of a low-hanging fruit, because if we restrict means to the most lethal types or the most lethal ways that people try to take their own lives, which is through guns, then we can make a huge difference in suicide prevention. So even though that was said to be the topic that people had the least interest in, because they also said they're interested in the types of suicide prevention that we can do over telehealth, I'm also going to spend some time there as well. I asked this question, what is the most difficult part of working with clients who have experienced suicidal thoughts or behaviors? And I've separated out the answers by general mental health on this slide, and the next slide is from school mental health. And part of what I noticed is that a large number of people talked about feeling concerned, worried, if they've done or said the right thing, whether or not they've provided the right resources to clients, whether or not they provided the right coping strategies. And there was also a significant number of people who talked about difficulty managing their own feelings, like anxiety, fears. It might be about whether or not they did what was most needed by the client, or whether or not there might be some challenges with liability issues. A number of people talked about the difficulty with hospitalizations for suicidal crises. There were concerns about quality of care that people receive when they're hospitalized, lack of coordinated care following discharge. that people are discharged from psychiatric hospitals without new skills to manage the suicidal ideations that they have. And then a number of comments around people who have chronic suicidality. So the extent to which hospitalization it's a good time to hospitalize somebody who is having chronic suicidal ideation, and also balancing the risk between the hospital and the community. And we've seen this especially among people of color and LGBTQ people, for whom going into an environment that is a locked environment where the people who are assessing whether or not their mental health is improving might have biases around race, ethnicity, around sexual orientation and gender presentation that they're unaware of. So these implicit biases can affect the extent to which the client or patient is assessed as getting better in that environment. A number of people talked about concern that clients might be suicidal between sessions, and whether or not the client would actually make use of the emergency services that the clinician or the mental health provider had provided to the client when they discussed suicidality. A number of people talked about increased concern about suicidality with substance use and gaps in service following their referral. So the clinician or mental health providers made a referral, but if there's a gap there, especially because of COVID-19 and shelter-in-place orders, there were concerns about whether or not people would get help or if they might have an increase in suicidality. As I mentioned, the professional liability. And then people who are in rural areas or on some of the islands talked about there being lack of resources, such as residential care. And then one person also mentioned being a suicide survivor. And I just want to put out there again that I think a number of mental health staff will have had personal experiences with suicide, either themselves or a close family member or friend. Many of us may also have worked with clients who have died by suicide, and this topic can really bring up a lot of emotion. I just want to normalize that and put that out there, inviting us to be very gentle and kind with ourselves as we go through this presentation. In terms of school mental health, people talked about fears that clients would not follow through on a safety plan, challenges that the parents would not access help as instructed for the student. There was also concern about lack of parental knowledge about suicide and lack of training for parents that is non-stigmatizing regarding suicide. Also concerns that school administrators would not follow through on recommendations, and that school policies themselves were written in ways that were essentially anti-therapeutic and could be more of a challenge to suicide prevention than might be immediately obvious to administrators who don't come from a mental health background. There were also mentions around lack of support for young people. So again, I really appreciate people who had provided that information and helped me to really think about how I would approach this presentation. And so I want to start off by talking about kind of a base level, which is that language matters. So whether we're working in a school mental health environment or we're working in mental health in general, the way that we talk about suicide, the way we talk about people who have experiences with suicidal thoughts and suicidal behaviors really matters. We can stigmatize people or we can work to destigmatize. And when we work to destigmatize issues around suicide, we increase the probability that somebody will talk to us when they have suicidal thoughts or feelings. So part of how we do this is by using language first. So instead of referring to someone by diagnosis, we wouldn't refer to someone as, oh, the schizophrenic. We would say someone who is living with schizophrenia. In the same way, we put the person first when we talk about suicide. So we'd say a person who has died by suicide rather than defining them as a suicide victim, a suicide contemplator, a suicide attempter. We would talk about a person who is thinking about suicide. That's preferable. Or to say people who have experienced a suicide attempt. As you'll see going through these slides, I do talk about suicide attempts, but I'm referring to a behavior there. I'm not defining the person by the behavior, if that makes sense. So just some overview of statistics on suicide in the United States. And if you're not familiar, suicide statistics that we have in the United States there's always a 2-year lag time. So the most recent data that we have is from 2018. You can see that in 2018, there were 1.4 million suicide attempts, which averaged about 132 suicides per day. There were 950,000 years of potential life lost prior to the age of 65. While men died by suicide more frequently than women, women attempted suicide more often than men. White men accounted for nearly 70% of the suicide deaths in this country, and firearms accounted for almost 51% of all suicide deaths. Again, I want to point out here that because firearms are so lethal, that when we think about means restriction, lethality of the type of tool that's used for suicide is really critical. And I'm going to be somewhat of a broken record on this topic as we move through. When we start to look at the data by race and ethnicity, we see that there are differences when we start to look at suicidal thoughts and suicidal behaviors. So from highest to lowest percentages of suicidal thoughts, we see American Indian, Alaska Native people, followed by white folks, black folks, Hispanic Latinos, Native Hawaiian and Pacific Islanders, and Asians. And then when we look at actual suicide attempts from highest to lowest percentages, we see American Indian, Alaska Native, Black, Hispanic, Latino, White, Asian, and Native Hawaiian and Pacific Islanders. And I do want to point out here that all of this data, we should always approach it with a grain of salt, because there's a lot of behavior that might not be immediately obvious. And I can talk about two communities in particular. One is veterans. I've worked with veterans for many years, and it's not uncommon that veterans will drive very, very fast, and especially veterans who served in Iraq and Afghanistan, because of the explosive devices that are used, the incendiary explosive devices that are used on the sides of roads in Iraq and Afghanistan. When veterans come home from those war fronts, they oftentimes drive very, very fast in the middle of the road because they're trying to avoid if there might be an IED on the side of the road. And so sometimes when a veteran dies from a collision, it's unclear whether or not they were having like a PTSD episode that's related to IEDs in the field from where they had served, or whether or not they were actually driving as fast as possible because they were trying to attempt suicide. Another community where it can be very difficult to kind of suss this out are with people who use injection drugs. I worked with a number of people who use heroin, for example, who would talk about what they would refer to as an F-it shot. And F is, you can, it's not polite language, so I won't say it here, but everyone knows what I'm talking about. They would say the F-it shot. So if a new batch of heroin were on the street and people heard word on the street was it was very, very strong, sometimes people would use that heroin without trying to gauge whether or not they would overdose on it because of the strength. And they would say it's an F-it shot. F-it shot. They would either get very, very high or they might die. And again, it's hard to distinguish sometimes whether or not that was an intentional suicide attempt or not. Kind of drilling down a little bit deeper for suicide in racial ethnic groups, we see elevated rates of suicidal attempts and suicide plans among Latina youth. From 1991 to 2017, we saw significant increases in suicide rates among Native American and Alaska Native women at 139%, and 71% increases in suicide rates among Native American and Alaska Native men. In terms of Black high school students during the same time period, we saw an increase of 73% of suicide attempts in that community. Continuing on, suicide in diverse groups in the United States, we see very high rates of suicide among veterans. It's 1.5 times higher for veterans than for non-veteran adults. And among LGBTQ youth, we also see very high rates of self-harm, 48% higher among lesbian, gay, and bisexual youth, and 60% higher among transgender and non-binary youth as compared to heterosexual and cisgender youth. We see suicidal thoughts 40% higher among LGB youth and 50% higher among trans and non-binary youth. Importantly, right now with COVID-19 and shelter-in-place orders, 1/3 of LGBTQ youth who are sheltering in place at homes with unsupported family have an 8 times higher suicide risk than other LGBTQ youth who are sheltering at home with families who are supportive of their LGBTQ identity. From a strengths-based perspective, it's very important to realize that just one person in an LGBTQ person's life can reduce the risk of suicide by 30%. So imagine that if you happen to be the one person who is supportive of an LGBTQ young person, your support could equate to a 30% reduction of suicide risk. When we think about COVID-19 and race and ethnicity, we see higher rates of COVID-19 in communities of color, and this is for a variety of reasons. One has to do with living conditions. So we see in densely populated areas that whether it's residential housing segregation or multiple generations living in a small apartment, or overcrowding in tribal reservation homes in Alaska Native villages, that can relate not only to an increase in spread of COVID-19 among family members, but also it makes social distancing very difficult, if not impossible. So if somebody becomes infected, how do they quarantine for themselves from the rest of the family? We also see from the living conditions where there's pollution, so whether it be polluted water or pollution like air pollution, we see increased rates of asthma that are related to COVID-19 infections, or if the water itself is toxic, or if people don't have running water in their home, how are they to wash their hands regularly, which is a key cornerstone to COVID-19 prevention. Additionally, there is difficulty accessing personal protective equipment, otherwise known as PPE, and medical care in many communities that are either rural communities or inner city areas as well. There's also overrepresentation in jails, prisons, homeless shelters, and detention centers among communities of color. Additionally, communities of color are at higher risk of COVID-19 because they're oftentimes essential workers. So whether they're working in healthcare, meat packaging plants, grocery stores, fast food restaurants, or factories, they're working in environments that have high exposure rates. They might be working in jobs that do not afford sick leave. They have no health insurance, or perhaps they have an undocumented status. Additionally, we're seeing higher rates of COVID-19 among communities of color, in part due to pre-existing conditions, such as diabetes, sickle cell anemia, asthma, high blood pressure, and cigarette smoking. Many of these are also associated with communities of color as well. When we start to look at the actual hospitalization rates by race, ethnicity, we continue to see disparities by race and ethnicity. And I just want to step back for a second and remind us all that race and ethnicity are socially constructed categories. There is nothing inherent genetically about people of color that should put them at higher risk for COVID-19. Rather, it is the socioeconomic status, it is the discrimination that happens at a systemic level that can relate to higher medical challenges, for example, those pre-existing conditions that I just mentioned that make for worse complications with COVID-19, either risk of infection or actual presentation of the COVID-19 illness, and the need to be hospitalized. When we think about what do we know about COVID-19 and suicide rates, well, not much, because as I mentioned before, there's about a 2-year lag period. But we are seeing that there's a reduction in people who are presenting in emergency rooms with suicidal ideation. We should not, however, interpret that lower presentation in ERs as meaning that people are having less suicidal ideation, but rather perhaps people are avoiding emergency rooms because the wait time is really long given COVID-19 patients, or perhaps they're trying to avoid ERs because they're trying to avoid exposure to COVID-19. We are seeing there are increasing calls to crisis lines ranging from 50% in one crisis line in New York City to 8,000% increase since the beginning of the COVID-19 pandemic in Los Angeles. And the National SAMHSA Disaster Helpline has received an increase of 891% of calls since the beginning of this pandemic. When we look back at similar at other pandemics, in 2003 for SARS as well as the 1918 flu pandemic, there were increases in suicide rates. And there's a projected increase in what's been called deaths of despair. So these are deaths that will be related to alcohol and drug use, as well as suicide and COVID-19. And they're projecting anywhere between an increase of 27,644 additional suicides to 154,037 additional suicides. What are the factors that might account for this massive difference? Well, they have to do with things like, how long does the pandemic continue? To what extent are people losing their jobs? To what extent do people have access to unemployment benefits? To what extent are people being forced out onto the street, losing their housing because they're unable to make rent? We do see, when we start to think about other major disasters, that we saw decreased suicide rates, for example, following 9/11. But we think that that might have been due to an increase in shared support that was following the crisis. SAMHSA provides us with this chart. This is a chart that shows community phases of disaster. We might think about this like the fires that happened in California in the last several years. There's kind of like a pre-disaster period, and there's an increase in stress that happens with the disaster, the impact of the disaster, we go down, and then we start to go up with the heroic response that we have on an individual and community level. We might hit a honeymoon plateau. But then there's this major crash with disillusionment as the reality sets in for all of the ways that the crisis is affecting people's lives in totality. And about a year from the disaster, things start to get a little bit better. And that's when reconstruction starts to happen. Well, this model does not work and does not fit for COVID-19 for a couple of reasons. One is because, as we've seen already in the United States, the disaster is happening in fluctuating periods across the United States. So while we saw really high rates in New York City initially, and the hospitals were being overwhelmed there, they were able to get their rates down lower. And in California, at the same period of time, was able to get the rates down lower. But right now, California is going back up again. And so we're having these hot spots across the country. So there's no linear progression, like this model would suggest. Okay, I'm going to take ourselves down for a second. It's a lot to think about COVID-19. It's a lot to think about suicide. It's a lot to think about racial trauma as well. And so I'm going to invite everyone to do a grounding exercise for 2 minutes. This is called a box breathing technique. I share it with you because it's something that I found to be useful in my own life. It's also something that I share because you might work with a veteran or service member at some point, regardless of where you work, unless you're in school mental health. Well, even in school mental health, you might work with the children of veterans or the children of service members. And this box breathing technique is something that's actually used in the military. Part of culturally responsive suicide prevention, as I mentioned previously, is drawing upon the strengths and resiliencies of the culture of the client that we're working with. And so when I work with veterans, I will oftentimes share this box breathing technique and say, you know what, I learned this from a veteran. This is actually something that comes from military training. Other culturally specific messaging that I'll use with veterans is I'll talk about the idea of leave no one behind, leave no soldier behind. That can be applied to suicide prevention as well. So I'm going to invite you to get comfortable in your seat, to please, oh, I see that audio was lost. Can you hear me okay now? I'm going to keep going, assuming that you can. Yes, you can hear me okay. Great. So I'm going to ask you to get comfortable in your seat, please. That means, having your feet in a comfortable position, your arms in a comfortable position. And I'm going to invite you to take a deep breath in to count of 4. Hold it for the count of 4. Exhale slowly to the count of 4, and no breath to the count of 4. You're welcome to close your eyes if you'd like to. If you have your eyes open, you'll notice that I'm going to be moving my finger like a box. And this is helpful for people to remember where they're at in the grounding exercise. Okay, so please take a deep breath in. 2, 3, 4. Hold it. 2, 3, 4. Slowly exhale. 2, 3, 4. No breath. 2, 3, 4. Inhale. 2, 3, 4. Hold it. 2, 3, 4. Exhale. 2, 3, 4. No breath. 2, 3, 4. Last time. Inhale. 2, 3, 4. Hold it. 2, 3, 4. Exhale. 2, 3, 4. Hold it. 2, 3, 4. Okay, so for folks who did that exercise with me, thank you so much for doing that. I invite you to enter into the comments box if you notice anything different about how you're feeling in your body right now, or how your emotions might be feeling. With taking a moment. It really didn't take that long, 1.5 minutes, 2 minutes tops. Oftentimes, I see some people are writing in feeling a little bit calmer, shoulders might be relaxed, feeling more relaxed. A large part of suicide prevention is being aware of the stress level and catching that stress level before it becomes a crisis. And this grounding technique through box breathing can be done anywhere at any time. I appreciate, let's see, who was it? Kelly just said that Kelly's feeling calmer and more focused. And I think that's an important piece as well, because when we start to get into a crisis mode, we downshift from our cerebral cortex, which makes it difficult for us to think, to plan, and to make decisions that we would make when we were otherwise calm. So again, the calming exercise helps us not only to feel more comfortable in our bodies, but it also helps us to make better decisions and to be able to focus on the task that's at hand in front of us. Okay, at the risk of bringing the stress back up there again, now I'm going to talk about COVID-19 and stress. So this is not going to be news to anyone because we're all living this. But of course, there is what some people, Reiger, Stanley, and Joyner, have referred to as a perfect storm for suicide mortality with COVID-19 and stress. We're seeing isolation and a disrupted sense of time, normalcy, and loss of control. We're seeing that media coverage is making for an incredible bath of stress constantly, depending on how much media we're consuming. We're seeing in the media reports of a worsening pandemic. We're also seeing misinformation. Initially, we were told that we should not use a mask. And of course, wearing face coverings are now a major part of COVID-19 prevention. We're seeing different pieces of information about whether or not a certain substance can suddenly clear our bodies of COVID-19, or other pieces of misinformation. There's also been significant racial stereotypes, specifically racist stereotypes that have been used around COVID-19, directed especially at Asian ancestry communities, and those have been repeated on some news channels more than others, but that has been in the media as well. There's significant economic stress, both on an individual personal level as well as at a mental health agency level. So for our clients, we're seeing clients who are losing their jobs. We're seeing, as I mentioned before, loss of unemployment benefits. Right now, people are still waiting to see whether or not the moratorium on evictions will continue into the future. There's also the digital divide. So as schools started to close the brick and mortar to start up virtual online learning, for families who don't have internet access, for families who don't have a computer, or for families where there's one computer and many people have to use it, that there's economic stress about whether or not their kids are able to continue to progress in school as well. From a mental health service perspective, for agencies that are dependent on Medicaid funding, we're seeing, due to the close of mental health brick and mortar shops as well, that there has been a significant impact on the delivery of services, which then impacts whether or not people or programs are receiving the funding that they had counted on vis-a-vis Medicaid. We're also seeing mental health agencies really struggling who have moved to telehealth, for example, but they're working with clientele who don't have access to reliable phones, or maybe don't have access to the internet. And the funding sources for those programs, nobody included when they first wrote the grants that technology should be a part of what could be paid for by the grant. And so our mental health agencies are suddenly scrambling, trying to figure out, well, sure, we can move all of our services to telehealth, but will our clients actually even be able to access them? There's significant distress reactions. We're seeing disrupted sleep, and insomnia has been shown to increase suicide risk 2 to 4 times for the general public and 18 times for those who are living with mental health challenges. We're seeing a loss of sense of safety. This could be from a fear of infection, resource scarcity. There were certain periods of time during the initial stages of the pandemic where you'd go into a grocery store and oftentimes many of the shelves would look very bare. And the messaging that we got again from the media was that there might be food shortages. In fact, that was not the case. The case was that there was a delay from the production of getting the food from the fields or from the factories or what have you into the grocery stores and then restocking the shelves in time. But the way that that was presented to the public was that there might have been food shortages. So that resulted in a lost sense of safety and a distress reaction. We are seeing an increase in physical symptoms, somatic complaints, irritability, distraction, increased use of alcohol and other drugs, and gun sales have gone up. In fact, there's been an 85% increase in overall firearm safety. Firearm sales. That was a Freudian slip on my side, sorry. So there was an 85% increase in firearm sales and 91% increase in handgun sales since March 2020 compared to March 2019. And guns at home tripled the odds of suicide. We see COVID-19 psychosis. So we're starting to learn more about COVID-19 on the body, and as an inflammatory disease, when the inflammation is around the brain, this is relating to COVID-19 psychosis. We also see post-ICU syndrome. So this is ICU stays in general can have this outcome, and we're seeing it as well with people who survived COVID-19 who lived through an ICU. So post-ICU syndrome includes increased risk of post-traumatic symptoms from 19 to 39%, increase in anxiety 23 to 62%, and depression 17 to 43% following physical recovery. And additionally, we're seeing, just like other illnesses that result in chronic cardiac and pulmonary illnesses, that COVID-19 survivors who are having that chronic pulmonary and cardiac increases have an increased odds of suicide by 2 to 3 times. Based on COVID-19 and our need to stay socially distanced from one another, we're seeing complications for dying and grieving in isolation. This results in prolonged and complicated grief. So a typical grief pattern is that after a period of grieving, people kind of adjust to some extent to the loss and they're able to go on. An experience of prolonged or complicated grief means that people do not have that type of recovery, and so their ability to function in daily life is disrupted for a much longer period of time, sometimes indefinitely. And so if we are not able to be with our loved ones when they are in the hospital and dying of COVID-19, we're not able to bury them in the ways that our culture has set forth for us. That's what can result in this complicated, prolonged grief. We're seeing increases in interpersonal violence, sexual abuse, and child abuse. As people are at home sheltering in place, those families who did not have adequate coping resources, and when they would respond to stress in general with interpersonal violence, we are seeing that escalated now. For people who have 4 or more adverse childhood experiences, otherwise known as ACEs, we see an increase in suicide risk by 38 times. 18% of people who survive domestic violence have, an 18% increase in suicidal ideation and suicide attempts among people who are survivors of domestic violence. And children who witness domestic violence have double the rates of suicide attempts, while victims of child abuse and neglect have 3 to 4 times greater odds of suicide later in life. We've also seen at this end of spring this last year that high school students missed critical milestones like proms and graduation ceremonies, and they were entering a job market during a recession. And then, as I mentioned before, there's significant stress and trauma to health professionals and mental health professionals, both because we are surviving this pandemic on our own while also being present to support the needs of our clients. We've already seen several cases of suicide of doctors who work in ICUs, in emergency rooms, paramedic drivers, and nurses. Part of medical training is this idea that death of a patient equals failure. In the same way that many of us might have been trained either explicitly or implicitly as mental health providers, that if a client dies by suicide, that we have somehow failed. And so there's this double burden on all of us. I really hope that at the end of this presentation, at the very least, I can create a sense of that we be kind and gentle to ourselves as clinicians right now, that many of us are struggling. That's normal. And it is very hard to survive a global pandemic. It's even harder, I think, to survive a global pandemic when we are the support person, not only for clients, but many of us are also care providers for family members or for friends or neighbors. As you might expect, we're seeing disproportionate mental health impacts of COVID-19 on specific communities, including people living with mental health challenges. As I mentioned, healthcare professionals, people who are incarcerated, refugees, older people, and people who are in care facilities, whether they're elderly care facilities, psychiatric care facilities, or other nursing rehabilitation centers. Just briefly, I'd like to go over what we're seeing thus far about the mental health challenges that are associated with increased outcomes, negative outcomes related to COVID-19. So before COVID-19 even struck, 45 million Americans had pre-existing mental health challenges. For people who are living with anxiety disorders, we might be seeing an increase in panic buying or trying different medications and treatments in an effort to cure themselves or prevent a coronavirus infection. We also might see compulsively checking the news. For people who are living with depression, the isolation from shelter in place and a fear might be amplifying depression. And this could result in an immobilizing fear, grief, sadness, lack of self-care, and ultimately suicidal ideation. For people who are living with obsessive compulsive disorder, we might see compulsive hand washing. So people might be washing their hands for 20 minutes under scalding hot water because the recommendation is frequent hand washing to prevent the virus. But for someone who's living with OCD, it might go to the extreme. We also see an extreme in sterilizing surfaces so that people will spend hours at times cleaning the surfaces in their homes, again, based on the recommendation that we clean things like doorknobs and such. For people who are living with eating disorders, we might see hoarding behavior, and this could be fueled by empty grocery shelves, but people also might be restricting their food intake with the idea that they're trying to ration food. When we think about suicide, people who are living with eating disorders are accustomed to physical discomfort and pain, and that can be related also to the ability to attempt suicide in various ways that are extremely painful. When we look at attention deficit hyperactivity disorder, ADHD, people who are living with this challenge might experience impulse control challenges like staying inside or avoiding shaking hands with people or touching doorknobs. They might also forget to wash their hands, and they might also be experiencing increased distraction if they're lucky enough to be able to work from home. And that could affect, of course, their outcomes at work. For people who are living with bipolar, we might see an increase in mood cycling that's being triggered by stress and fear. And for people who are living with schizophrenia, we might see increased disorientation from shelter-in-place orders. So for many of us, if we walk outside, like at my family, we go outside every night and we take a walk, and the streets have been empty, at least in the beginning of the pandemic, more so than now, it was somewhat disorienting. Or to walk into a grocery store and see shelves that were empty. But for somebody who's living with paranoia as a baseline, and who have difficulty interpreting the things that are around them to figure out what's reality or not, so somebody who's living with schizophrenia, paranoid type especially, they might be especially challenged around interpreting what they're seeing around them. And that could increase the risk of suicidal ideation as well. So there's some significant challenges and limits to mental health resources and support related to COVID-19. As I mentioned already, the emergency rooms, mental health clinics might be closed or transitioning to teletherapy. Many of the social events and locations that people might have used for buffering or distracting are not accessible to them right now. So for example, if you look at the bottom of this slide, some of the places that people would receive self-help support. So it might be 12-step fellowships like AA or NA groups, or a self-help community center for peers who are living with mental health challenges, powwows for folks who are Native American, or veterans of foreign war, VFW halls for veterans, LGBT community centers. Most of these self-help places or community environments were in person. And now that we've gone to a shelter-in-place model, people may not have as immediate access to them. I want to point out to you, and again for a plug to download the slides when you have a moment, that those things that are in the blue underline, that's a hyperlink. I've actually been able to find many alternatives in a virtual space. So that I've found AA and NA groups that your clients can access, or that any of us could access, frankly, online, and so on. Importantly, staff who historically would identify early symptoms, so we're talking about our school counselors or school mental health staff or an employee assistance program, these folks do not have, they're not able to see students, families, employees as regularly, so they may not be picking up on the warning signs that they would see when we were all in person. One of the things that I'm making a point to share with you all during this presentation are a variety of apps for smartphones. The first one here is a COVID coach app. This is something that was created by the National Center for PTSD through the VA. This is a really, I think, interesting app that was created. I really appreciate all of the folks who created this so quickly, but this app is really helpful for people to manage the stressors that they're living with on a daily basis that are specific to COVID-19. So the tracker can help people to check their moods, to measure the growth towards personal goals, to visualize progress over time, and education about coping during the pandemic, tools for self-care, and how to improve emotional well-being. So I'm going to stop again and take a moment to do another poll. This question is, have you conducted suicide prevention over telehealth? And your options are yes or no vote. Perhaps it's not applicable. So thank you so much. I'm seeing people very quickly entering their responses. I'm asking this poll question right now because we're about to start to move into that phase of talking about suicide prevention over, you guessed it, telehealth, and making it specific to our COVID-19 pandemic environment. You might be thinking, well, gosh, what is suicide prevention over telehealth? Well, this could include things like a suicide assessment or interventions like calling 911 or a safety person for a welfare check, safety planning, or dialectical behavioral therapy skills and self-regulation. Okay, so it looks like we've got almost 50-50 folks saying yes and no that they've conducted suicide prevention over telehealth. Okay, thank you so much. So I'm going to end this poll and we'll move on to the next slide. So what I've done here is I've created recommendations for telehealth and suicide prevention during pandemic times in two ways. The first one is kind of like the first session that you do with folks, and then the next slide is going to be things that you would do recurring every session that you have over telehealth thereafter. Now you might say, Ramirez, wait a minute. I need to do this with my clients that I've already been meeting with over telehealth. And I would say to you, fabulous. But let's just pretend that the next time that you meet with them is that first session if you have not done these things before. Okay. Okay, so the first thing that I would recommend if you are planning to do telehealth but haven't started yet, the very first thing before that even first session is to develop a system for managing imminent risk. It can be extremely difficult, whether you're doing telehealth by phone or whether you're doing it through a video conferencing app like Zoom. If you are working with a client who's expressing imminent suicidal ideation, that they are at imminent risk of hurting themselves, you need to keep them in that session while you're simultaneously reaching out to emergency services to get them help. That can be much more difficult than might seem otherwise. I don't know about you, but when I have worked with clients who are at imminent risk of hurting themselves, my heart starts pounding. I start to breathe faster. I start to sweat because I feel the intensity of wanting so much to be there for this person. And so physiologically, I'm starting to react in the crisis as well. And it's very difficult over telehealth to keep the client engaged while reaching out to those emergency services. So I just encourage you to figure out your plan ahead of time. And this is specific, like you do telehealth, you always have a phone next to you. You do telehealth, you always know how to immediately contact emergency services in the city or town where your client is located. Because if I am working with a client, for example, who's in another state, and I pick up my phone and I dial 911, I'm getting my local emergency services, not the services where the client is located. Now, after I figure out how to do this, this dance essentially by keeping the client on the phone or in telehealth and then also reaching out to emergency services, I want to practice it. I'm going to do it several times. I recommend doing that with a colleague. Okay, once you have that all figured out, in your first session with the client, I encourage you to start off asking where they're located and write down the phone number on a piece of paper. Because again, if you should lose access to internet, you're going to, or excuse me, if you, for some reason your computer crashes, you don't want the phone number to be locked in the computer. You wanted to have it on a piece of paper. You're going to want to explain to them your crisis management, potential crisis, and lost connection protocol. So crisis management. Over telehealth is different than in person, right? So similarly to in person, a client could say to me, Eliana, I'm gonna kill myself now. That's a very clear imminent risk immediately now. Okay, I need to explain to my clients if I hear that or anything that makes me think that they are at imminent risk, what I'm going to do. Potential crisis is a little bit trickier. Potential crisis is like, you know, when we're meeting with somebody face to face in the session and they might get ticked off and stormed out of the room, I can always follow them out to the parking lot to see if they're okay. In telehealth, if somebody gets ticked off and they storm out of the Zoom session, and then I call them to see if they're okay and they don't answer the phone, I don't know whether they're just sitting there looking at the phone and cursing at me or if they are actually in the process of injuring themselves. So what I tell my clients over telehealth is, look, if you storm out of this telehealth session, I'm going to call you back. I'm going to try 2 times. If you do not answer the phone, one of those 2 times, I have no choice but to assume that you are an imminent risk, and these are the things that I'm going to do at that point. It's not meant to be punitive, but it is meant to explain to the telehealth client that the risks are different, and this is how I as a clinician have to manage the difference in risk vis-a-vis if I was in person with them. Then the last part is a lost connection protocol. So let's say there's an interruption to internet service or something, and I don't think it's because the client stormed off. I need to let the client know, look, I'm going to contact you. Please don't try and call me, because if we're trying to call each other at the same time, we could end up with a whole bunch of busy signals. So just letting them know what the process will be if we lose connection. During that first session, I really encourage you to assess self-harm, not only for right now, but the historical self-harm. Also, if they have a history of substance use, both substance use and substance use disorder, and whether or not there's any other impulsivity and risk-taking behavior. I encourage a suicide assessment and providing crisis line and self-help resources irrespective of what you find when you do that assessment, because in COVID-19 pandemic world, as I'm sure many of you are experiencing, things can change very quickly with our mental health. It was actually 2 days ago that I learned that one of my family members is living with COVID-19 and has recently been hospitalized. And so these things can happen very quickly to us, and it can happen very quickly to our clients. So a client who's seemingly pretty well today could very quickly not be well in the near future. Or maybe they suddenly lose their job, or something else happens like is happening for many of us these days. I encourage that if the client is fortunate enough that they have somebody in their life who could be a support person, that you obtain a signed release of information form and contact information for that support person. And as I'll explain later, I really encourage you to actually make contact with the support person so that should you ever have to contact them, let's say your client Susie Q doesn't show up for a session 1 or 2 times and you're really worried about them, you need to reach out to the safety person, that when you reach out to them, it's not the first time you're doing that. Or let's say Susie Q makes it to your session and you realize that she's really starting to edge closer to a crisis and you need to ask the the safety person to help out. You want them to have some skills already under the belt that they might be able to use at that time. And then ultimately also, regardless again of what you found in your assessment, to actually do a safety plan. And I'm going to go through safety plans in just a little bit here. So I talked about your first session, and then this is actually like all subsequent sessions. And I apologize, this title here is shifted. This actually should be like every session thereafter. So every session thereafter, we always start off asking the client where they're located and have the callback number. We're going to want to assess suicide risk. And we want to especially, again, be cognizant of any COVID-19 specific things that might have come up and whether or not their access to lethal means might have changed. Now in California that we're edging towards probably going back down into a much more strict shelter-in-place order, when that happens, we are encouraged, for example, to get 30 days worth of medications in our home so that we don't have to go out to the pharmacy. Well, if I bring in 30 days of medication, that might be an increase of lethal means that are suddenly in my home. So again, we just want to constantly be checking in every time that we meet with a person. And we want to ask them if they've used the safety plan that we created with them since our last appointment. And if so, what was it like for them actually using that safety plan? And then revise it as needed, of course. If we find that there's an elevated but not imminent risk of suicide, you might want to do some more frequent check-ins. And this is in the literature quite a bit. That if, let's say, I'm meeting with Susie Q today, we do that suicide risk assessment, and you know what, she's at low or moderate risk of suicide today, and that's higher than before. I'm probably going to say, hey, Susie, you know what, especially if it's at moderate risk, Susie, I'd like to check in with you before our next session. And it could just be a short check-in, maybe a 5 or 10 minute call. But that's something that actually can really make a difference to clients if you have the capacity to do that. I'm going to encourage them to connect with their support person and especially to reach out to virtual support groups. Isolation is a major factor for many people regarding suicide. And so the more that they connect to peers, it's very helpful. But of course, in COVID-19 world, we're less able to do that face-to-face. So virtual support groups are really helpful. And down in the box, the gray box in the bottom left-hand corner that says handouts, the line that says all handouts, within those handouts, I have prepared a list of resources that are specifically virtual for online telehealth support that you can share with your clients to find things like virtual support groups. And then you might find that you'd want to refer your client to somebody else. So for example, maybe a medication adjustment might be helpful. So you would want to make sure that you're encouraging them to connect with a psychiatrist or other MD. So I mentioned to you that if your client is fortunate enough to have someone they could list as a support person in their safety plan, that you would want to actually reach out to them. And the way that I do is I say, Susie Q, I'm so glad that you said Joan, your friend Joan could be your safety support person. Should we ever need to ask Joan to step into that role, I think it would be really helpful to her if we could meet with her ahead of time, and so I can share some resources with her so she can be the most effective support person to you. Are you cool? Would you be amenable to that? And hopefully Susie Q will say yes. And then I get to meet with Susie Q and Joan at the same time. Or maybe Susie Q says, sure, Dr. Ramirez, you can do that, but I really don't want to be a part of that discussion. Okay, fine. But I'm doing it with Susie Q's understanding. I do the same kind of thing if I ever need to call the crisis line, by the way, when I'm with a client. I'll say, you know what, I'm feeling like I need to call the crisis line right now to get extra support for you. Would you like to be a part of that call? And then I'll do a three-way call. And it's a good idea to figure out ahead of time on your cell phone, if you're using a cell phone, or if you're making a call via your computer, how to do a conference call so that you could have your client and the crisis line connected at the same time should you need to do that, or your client and their support person. But okay, fast forward. Let's say that I'm on the call with Susie Q and her support person, Joan. I am providing to Joan crisis line number. And by the way, there are multiple crisis line numbers. For LGBTQ clients, whether they're children, youth, or adults, there are a variety of crisis lines that are specific for them, like the Trevor Project for young people, the National LGBT Hotline for youth and adults. There's a SAGE hotline for elder LGBT people. For veterans, there's the National Crisis Line, but it's 1-800-273-8255, but you dial 1 to speak to someone who's specifically trained to work with veterans. Okay, so I provide a crisis line that's specific to the client. I'm explaining to the safety person when to call. Guess what? You do not have to have a client who's in suicidal crisis at this moment to call the crisis line. And I've done this with veterans where I'd say, gosh, I'm feeling like things are getting a lot more challenging. Let's call the crisis line. Let's not wait till it's an actual suicidal crisis. Let's call now. And then I'm explaining to this safety support person how to call with or without the client. Again, I'm telling them it's great if you feel like you need to call the crisis line to do it with your friend Susie Q. If Susie Q is unwilling to do it or you can't get a hold of Susie Q and you call alone, that's fine. But if you feel like a crisis line needs to be called, call it one way or another. I'm providing the completed safety plan with means restriction, which I'll get into in a little bit, and self-regulation strategies. So these are things like the box breathing and other things that can help the body to slow down from that crisis mode so that people can make more sound decisions. Importantly, I'm providing to Joan a psychological or emotional first aid app. And very briefly, if you haven't heard of what this is, most of us walk down the street. We get a scrape on our leg. It's bleeding. We know that when we get home, it's a good idea to clean out the wound and put a Band-Aid on it. Why? Because if we don't do that, if we leave the wound open, it can fester and become very, very badly infected and start to affect the rest of our system. Eventually, we could end up with gangrene, worst case scenario, right? When we have injuries to our mental health or our psychological state, let's say it's an experience that we have been betrayed by a friend, or we feel a sense of shame, or we feel like we're depressed or isolated. If we don't start to address those feelings immediately, they can fester and fester and get worse and worse and worse. And for some people, they can end up in a psychiatric, psychological, emotional crisis. Psychological emotional first aid helps us to be present to a person who has had some kind of an injury, psychological injury, to help them essentially with that Band-Aid so it doesn't continue to get worse. Psychological emotional first aid can be done by anybody. You don't have to be a licensed clinician. You don't even have to be a mental health support person in any way. Any family members could do this as well. There's an app. I'm really big on the apps, so of course I'm going to share with you an app that you can easily share with that safety support person. You also want to give the safety support person your contact information and an explanation that you are not 911. Golly gee, you are not emergency services. If they need to speak to somebody in an emergency situation, they should not be calling you. They should call emergency services. Hopefully, your client, Susie Q, is fortunate enough to live in a community where there are emergency psychiatric services. So perhaps maybe the police do not need to be called. I do want to take a moment and very clearly, in unequivocal terms, state that if we have to call 911, it's really important to think about if the police end up going to that person's home, what might the outcome be? I will never forget the time that I was working with a veteran by phone who I had to do a safety check on. And that meant that I had to call 911. There were no other options in that person's home. And I told the veteran I had to do that. And the veteran very clearly stated to me that he was going to meet the police on his front yard with his guns drawn as well. I don't need to explain to people also that in this day and age, Black people's experiences interacting with the police are very different than most white people's experiences interacting with the police. In fact, 30% of deaths among Black people that are due to an interaction with police, 30% of them, the reason why the police were called in the first place was because of a psychiatric symptom. I'm not telling you don't call 911. I'm not telling you don't call police, but I am saying that if there is an alternative like calling emergency psychiatric services, in the town, that might be a good way to go. The other piece is to have a very explicit conversation with clients ahead of time. If I have to call for emergency services, let's just be direct about what emergency services are available and what I can, what kinds of services I could get to help you and what the potential implications might be. And then finally, I think it's really important to share with support people websites like Now Matters Now and the National Association of Mental Illness. Now Matters Now is one of the best resources that I'm sharing with you today, hands down. This is a website with a variety of videos of people who have personal lived experiences with suicide, who are sharing videos talking about the things they do when they have suicidal crises come up so that they can get through those moments of crises. Ursula is the woman who has organized this website. She is a psychologist, and she is also someone with personal lived experience with suicide. And she includes a variety of videos on this website that include dialectical behavioral therapy skills, DBT skills, that help people to get through crises moments. And when I think back to those of you, the 107 of you who get A++s for completing the needs assessment, learning needs assessment, thank you, that I had sent out, many of you asked for strategies, skills that could actually be used by clients in the moment when they are in crisis that could be used instead of acting on the suicidal behaviors. This website is the top thing that I can share with you. Ursula and the other web programmer folks who created this website have put together, well, it's essentially, it's a survey of people who go to the website. And so they've been able to show that people, when people spend time watching these videos, that their stress level goes down. And it's things like videos about the dive reflex. So if you're not familiar, the dive reflex is that when we immerse ourselves in very cold water, it could be just our faces, it could be our entire body. Very quickly, we start to self-regulate, and it's our breathing starts to slow down. Our heart starts to slow down. We move from a state of really high agitation, be it anxiety, anger, sadness, and we start to self-regulate and come into a more even keel moment. And in fact, Ursula has a video that's called, I think it's called like water therapy or something like that. And what she does is she's recording herself. She just has a very stressful day. Her hands are shaking. She just read an email that really upset her. And she draws a very, very cold bath. And she gets into the water and she's doing biofeedback. So she's using her Fitbit on her watch to regulate her heart rate and I think maybe her oxygen levels as well. Anyway, as she gets into the bathtub and she's talking the whole time. So you're hearing her read off how her heart rate is slowing down. And you can hear her starting to calm down as she's in the water. It's amazing. She also has videos of working with a client next to her where they both take tubs of water with ice in it and they put their faces in it for intervals of 30 seconds. And they talk about how it's helping them to calm down and self-regulate. So if you have clients who would be open to trying this, but they don't have bathtubs or a swimming pool, this would be an alternative they could use as a tub of water. So there are a variety of skills that people can use in the moments to help themselves calm down, because ultimately, suicidal crises are typically time-limited periods where the person's coping strategies have been overwhelmed. And the brain is essentially misinforming the person that the only option to manage those overwhelming feelings is to die. If we can get somebody through that crisis period, the thing that made them feel that way in the first place may not have changed. They may not have suddenly gotten a job. Their family member, of course, will still be in the hospital with COVID-19, whatever the thing is. But if we can get them through that period when their body was so revved up that they couldn't think beyond suicide as an option, then oftentimes they will feel a little bit different later. What I oftentimes tell my clients is no feeling is final except with suicide. And for clients for whom it seems like this might be okay to say, I'll tell them, you know what? That bridge is always going to be there tomorrow. If you can hold off on making the decision today until you're in a place where you make a decision when you're really calm, that oftentimes can be really helpful. Because what we know from people who have survived suicide attempts is that oftentimes they will tell us later that as soon as they made the attempt, they had a sense of regret, that they wish they hadn't done that. They didn't actually want to die. They just wanted relief from the overwhelming pain they were in. And at that moment, again, it seemed like suicide was the only option. National Association of Mental Illness website is another really important website to share, because there are incredible resources for family. There's a family-to-family program, for example, where parents can learn about mental health challenges and resources to support their kids. There are support groups that are online and a variety of other amazing resources. So these are great things to share with a support person. Here I've provided some telehealth suicide prevention resources. I'm not going to spend too much time on this because I invite you to get in there and download this presentation for yourself. So when I started to think about it, like, okay, you know, what do we have available to us right now as clinicians who are doing suicide prevention over teletherapy context and in an environment where we can't be face-to-face with the support people or resources that might be typically called upon. And isolation is such a big deal, both with suicide and with shelter in place. I thought videos are the way to go. So I've curated a number of videos here, pulled them all together, that can be shared with your clients. And it also, if you're maybe in the earlier part of your career, and I saw this from some of the learning needs assessments that I saw, people might feel like they're not sure if they have the resources or experience or training necessary to meet the challenge and the call of the moment when they're present with a client who's dealing with serious suicidality. These videos can be a great place to learn about them. I think they're also really important for those of us who are working cross-culturally to learn about the distinct themes that can come up in different cultural communities. So for example, when working with veterans, it is very common that veterans who are dealing with suicidal ideation will be experiencing a sense of survivor's guilt. This means that maybe they've been in combat and everyone else that they worked with in their platoon died, and they're one of the only survivors, and they then have an incredible sense of guilt that they survived, and they feel like suicide is the only way to deal with that extreme pain. When we look at research with Latina youth, for example, we see that oftentimes there's a stressor between the cross-cultural experiences of their parents or grandparents and the culture from the country of their origin to what the Latina youth is experiencing when she goes to school and in the community, and that the disjuncture between those cultural values can lead to an overwhelming sense of dysregulation. So I put together videos, and then we see also with LGBT youth and adults, we also see, especially with LGBT youth, themes about bullying, hate crimes, rejection and violence from family of origin when these youth come out. And so again, it can be very helpful. And if you happen to have read that article that I sent when you registered, there are some tools that are starting to help us think about these themes that are differences across culture that relate to suicidal ideation and behaviors. So now I'm going to get into, and I'm thinking about our time here, assessing suicide risk. There are several tools that are out there. Today I'm going to talk about two: the Columbia Suicide Severity Rating Scale and the ASK, which is the Ask Suicide Screening Questions. Both of these are evidence-based tools. The CSSRS has been found effective over telehealth. The ASK is something that our governor in California and the state public health department and others are really encouraging us to use as well. They're both free. They're available online. What I like about both of them is that it's very clear, depending on what the answers are by your client, what you should do next. If they're at imminent risk, if they're high risk, for example, looking at the CSSRS that's in front of you, if the person answers yes to the yellow boxes and the orange boxes and the red boxes, that means that they're at high risk. And down here is where there are directions of what you should do, recommendations to manage that high risk. If you're interested in using this tool, but you'd like to find some training on it, there are free videos that are available on YouTube where you can actually watch different people administering the CSSRS. You don't have to be a clinician to use this tool as well. People in law enforcement use it. Teachers can use it. Other family members and friends can use them as well. And this is the Ask screening tool. And there are specific recommendations among if you were going to use this tool with youth during COVID-19 and with adults during COVID-19. And if you were to pull up those handouts from the handout box on your screen right now, I've included kind of a decision pathway that comes from the Ask creators regarding working with youth and this tool. So bird's eye view about suicidal crisis, I explained earlier that this is oftentimes about a person's coping ability being overwhelmed. There are acute moments of stress. Problem-solving decision-making may be interrupted. And right now, especially during COVID-19, their access to support resources and sense of connection may be thwarted. I'm going to step back and say the reason why the Now Matters Now website includes all of these DBT or dialectical behavioral therapy interventions like the cold water therapy is because Linehan, Marsh Linehan, who created dialectical behavioral therapy, recognized that what can happen for people is they need help with emotion regulation. And so, very briefly, I'll explain this. If you imagine most people from 0 to 100, 100 being the most stressed out ever, 0 being the most relaxed ever, if most of us are walking around at, say, a 20, and something stressful happens, our stress level goes up, say at a 50, and then oftentimes we'll do some problem solving and resolve and we'll go back down to the 20. Well, for some people, they're not functioning at a 20 every day, they're actually functioning at an 80. And so when a stressor happens, like COVID-19, they go from an 80 to 95 instead of the 20 to 50. And for the people who start out at an 80, they not only get up to that higher number faster than the people who start out at 20, but it takes them longer to resolve and to go back down to their baseline. And so whether it's somebody who is living with what's called borderline personality disorder, or they're living with any number of anxieties, or also depressions can also do this. People that when that injury, the psychological or emotional injury happens, they end up going up higher and they're upset longer. And because they're closer to 100, that can be why we see for some people they have chronic suicidal ideation. Because remember, suicidal ideation, oftentimes it's not that people actually want to die, it's that they want the pain to stop. So for people who have chronic suicidal ideation, repeated time periods where they think about suicide, it can actually be like a safety valve or a pressure valve for the brain. Because what's happening is they start out at 80 and then they're suddenly at 95 and they can't think about how they can cope. They can't imagine an alternative. And so what happens is the thought of, well, I could always take my life. And that creates a little bit of pressure valve so that they can get through the moment. So I know some of the questions that people asked were, well, how do I know if the client that I'm working with who has repeated suicidal ideation, if today they tell me that they've got suicidal ideation, is it really a crisis? What should I do? I think the recommendation always, no matter how many times they've told us before, no matter how many suicide attempts there have been, if somebody tells us that they are at risk of harming themselves, we have to take it seriously and assume that they actually are at risk. If people say that they are at risk of harming themselves and they're not actually at risk of harming themselves, and they're saying that because they know that it will make you jump, then jump. Because there's no way for us to know whether or not they'll be here tomorrow. We always have to take people at their word. Okay, so another poll. This poll is, do suicide contracts, that is requesting or making the client promise that they will not hurt themselves, do suicide contracts reduce the incidence of suicide? Yes or no? And I asked this question, I did see some people who had completed the learning needs assessment said that they were wondering whether or not, one of the things they worry about in between sessions is that their client promised them that they would not hurt themselves, but they're not sure if the client will keep that promise. So do suicide contracts work? Okay. Spoiler alert, because of the time frame, I'm going to actually go ahead and end this poll here. We got 30% people say yes, 70% say no, And the answer is no. Suicide contracts do not work. In fact, they can create major problems with rapport between the clinician and the client. Clients can oftentimes feel a couple of things. One is, this clinician doesn't actually care about me. They're trying to protect their own liability. They're trying to protect their own tail. Or two, this clinician has no idea how much pain I'm in. And if they were actually experiencing the amount of pain that I was in, they wouldn't be asking this of me. So suicide contracts do not work. They can actually be harmful. What we do know that does work based on research are suicide safety plans. These are brief, evidence-based interventions that are most effective when they're culturally responsive, when clients create them themselves with us helping them out, when they reduce stigma, and they maximize social support and connection. There are a variety of suicide safety plans out there. I have provided you links to 5 of them. They should be written in the first person. So rather than Susie Q will do blah, 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 it would be instead, I, as Susie Q, I will do blah, blah, blah. It's really important, as previously mentioned, that support people have a copy of this safety plan. And of course, that the client does as well. Here's one example of a safety plan. This is by Stanley et al. And this is kind of like the bare bones. So safety plans, and of course this screen is so small that I can't actually see it. So I'm going to go to my notes here. Safety plans ask people to talk about, my eyesight is going with my age here. Oh my gosh. So step 1 are warning signs. So these would be thoughts, images, moods, situations, or behaviors that a crisis might be developing. 2, internal coping strategies. And this is an important point to say to the client, what have you done in the past that's helped you to survive to this moment? Let's write down some of those things. You know that they work. Personal coping strategies. Number 3, people in social settings that provide distraction. So these would be people who you don't have to call and tell them, hey, I'm feeling really stressed out right now, but instead you could be, hey, I'm just calling to hear, say what's up. Maybe this is somebody that I can play video games with online as a distraction or something like that. Or I can call just to talk about the recent recipe that they used. Number 4, people that I can call to actually ask for help. So these are the people that I can call and say, you know what? So-and-so today, I'm really down. I need somebody to help me because my mood is really getting wonky. Step 5, these are the professionals or agencies I can contact during a crisis. And it's really important, again, during COVID-19 world that we check to make sure whether those places are actually open, whether their hours have shifted, or whether they're open only in a telehealth virtual platform or not. And then step 6, and absolutely essential, making the environment safer. And as I've repeatedly said, especially thinking about the lethality of the thing that they might use to injure themselves is critical. Here's another example of a safety plan. This is by the Now Matters Now website. I like it because it has a variety of examples of things that people can do to help themselves in the moment. And it also uses this color coding system, thinking about suicidal crisis like a fire. There is, ding, 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 another app that you can use and share with clients. I think this is really helpful because we want clients to have the suicide safety plan with them at all times. I do recommend going in and checking out these apps before you share them with clients, but you can see, like with the suicide safety app, there are like warning signs, coping strategies, reasons to live, places that could be distractions, and a variety of things that are already built into the app, and then they can add to the app as necessary. Here's another suicide prevention app. And I want to take just a minute and a half to describe an example of culturally relevant suicide safety plan. I was working with a veteran who is Native American who served in Vietnam. Had been working with him for a while, and I knew that he had repeated experiences with suicide attempts and current suicidal ideation. He was at a low risk, but it was definitely there, and he had some chronic health things that were going on. So if he were to get really bad news from his doctor about any of his chronic health things, I could see that that suicide risk could shift quickly. So we took it as an opportunity to update his safety plan. This was prior to COVID-19. Anyway, I knew from having worked with him that he had taken He'd engaged in a number of Native American traditions and practices that were very important to his mental health. One of them was attending a sweat lodge. Another was an activity where he went into the mountains with a group of people and a leader, and he described being out there for an extended period of time and having a vision, and that was the purpose of why everyone went out to do this. And he talked about collecting rocks and making them in a circle for himself, and everyone did this for themselves, and that he sat in the middle of these rocks. And at a certain point, he had a vision of someone that he referred to, and I quote, as a sentient being. And so his sense was this sentient being was there watching out for him. Okay, fast forward now to when we're doing the safety plan. I talk about in the safety plan, well, if he had actually planned out how he would injure himself if he were to get to the point. And he said, yes, his plan was that he was going to hang himself from the rafters in his home. So I suggested to him, well, what if we get a picture of the mountain where you had that experience of seeing the sentient being? Could you put that picture next to where you would put the rope? Because if you're in crisis, this would be to remind yourself that that sentient being is always there, always looking out for you, that you're never actually alone. Wasn't that the message that you got that day from that sentient being? And he said, yes, it was. And so, it gives me shivers thinking about this now still. And so I said, okay, well, let's get an image of the mountain. And I was like, what mountain is it? And he was like, he didn't know what the name was in English, essentially, of the mountain. And so we ended up spending a lot of time that day. I was messaging friends on the Tanahatam reservation going like, hey, do you know what it was up in northern Arizona? I was like, hey, do you know what this mountain is? This is the only word that he knows for it, da da da. But of course, if we put in that traditional name of the mountain into Google, it would not come up. So anyway, eventually, good news, we did find the English name of the mountain. We were able to print it out for him, and he was able to put it there. But this is just an example of how we can build upon the cultural strengths of the clients that we work with and actually build it into the safety plan. Okay, moving along. Means restriction, absolutely essential. We know that when somebody makes a plan to kill themselves, there typically is a reason why they're choosing the thing that they're choosing. Let's say somebody is imagining that they're going to drive into a tree. Well, they're trying to make it look like an accident. So if you were to take away the keys to the car, then it's unlikely that they are going to hang themselves, because that's obviously not an accident. As I've suggested before, certain things like guns are so lethal that people typically don't survive them. And so reducing access to guns in a variety of ways can be can have a huge outcome for saving lives. The majority of people who end up engaging in suicidal behavior have not made elaborate plans. Oftentimes, it is a matter of minutes to hours between when they have the thought and when they take action. That said, when we're doing our suicide assessment with people, we might get a sense of, if they were to act on any of these feelings, that they would know kind of what they were thinking about doing. So for example, it might be they would plan to overdose. Okay, well, if they would plan to overdose, now is an important time for us to look at what are the medications that are available in the house and how do we make it a safer environment. And so if you look up here in these pictures, many states have, major chain pharmacies that have these boxes, the red box in the bottom. This is a place where you can dispose of unused medication. Maybe they had a surgery a long time ago and they didn't take all the pain meds. Well, this would be an important time to get rid of those, and you can drop them off in the box. However, COVID-19 world, people don't want to walk into pharmacies, so you can instead mail them in this thing that's called takeaway. So you can order these envelopes, put the medications in them, and the United States Postal Service will take those medications away and dispose of them properly, not into the oceans, not down a toilet, right, where it can affect the ocean life or the water supply. There's another option, which is gel that it's powder, and you pour it into a bottle with medications, you add water, the powder becomes a gel, the pills are suddenly not able to be swallowed. So there are a variety of things that you can do. If you were to go to this link that says Earth 911 medication disposal locator and put in your client's zip code, or your client can do this for themselves, that will pull up places where they could dispose of their meds if they needed to do that. And this disposal gel I mentioned here. Gun safety, there are a variety of things that people can do. They can put guns in a safe lock. It's in a safe, and that has like a code to it. It's really, really important. If your client is a child or a teenager and their parent or someone else in the house has a gun and they keep it in the gun safe, you need to ask the child or the teenager, do you know the code to the safe? Because many times they do know the code to the safe, and therefore then the safe is not working the way it's intended to. There's a really important video here. It's this gun access underlined. This is actually a really important project that's being done by a public health professor, I think at Harvard. She's actually working with gun shop owners. And they've done some really profound work. So for those of us who work with clients that are part of a gun culture, that they feel very, very threatened if you start to talk to them about reducing access to guns during a mental health crisis for themselves or their family members, this is a great place to go, because it turns out that a number of the values that are part of the gun owning community, like protection of family, protection of home, these values also can be directly applicable to suicide prevention. And so that's where you see the sign that says gun safety rules. And they've added another, essentially, commandment, I think is the way that they talk about it, to these gun rules that are around suicide prevention. Some great videos also in here about bridge nets and volunteers. So these are people who walk along bridges, especially the Golden Gate Bridge in San Francisco. It's so iconic. People come from all over the United States to jump from this bridge as a means to take their own lives. And there are volunteers who walk the bridge to keep an eye out for folks who might be in psychiatric crisis, and also talks about the idea of nets that they put along bridges, underneath bridges, to catch people. Given the time, I'm going to kind of get through some of this, but again, you've got the links so you can check them out on your own. Suicide crisis, suicide prevention starts long before a crisis. I really like this DBT and CBT skill of thinking about feelings from a thermometer perspective. So suicide prevention actually starts at the 5. It starts way before somebody's in a complete risk. If we had done that box breathing activity when people had just been almost in a car accident, for example, we would have had to do it for a much longer period of time to have the same calming effect as it did. Then we were just sitting here listening to a presentation that's probably pretty stressful. So we really want to encourage our clients to be self-aware and to start using these skills when they're lower down. That's part of what happens with whether or not someone will be able to make use of a safety plan. There are a variety of alternative behaviors that people can do when they're having suicidal ideation, and before they get to suicidal ideation, back when they're at the 5. And again, many of these are on the Now Matters Now website, like the cold water bath, stop, drop, and roll, opposite action. I also want to point out this song called Weightless. It's by Marconi Union. It was created by neuroscientists and musicians out in the UK who created a song where the tonal beat is so low that it actually slows down the heart rate. And 65% of listeners have reported a reduction in stress and anxiety just by listening to this song. Variety of other activities people can do to help themselves either distract themselves from suicidal thoughts or to self-regulate, to slow their body down from that crisis phase. Another app, this is a virtual hope box. It has a variety of activities that can be used for self-regulation and distraction. From the CBT perspective, cognitive behavioral therapy, it can be really helpful to pay attention to our thoughts, because our thoughts affect how we feel, affect how we behave. And especially right now during the pandemic, there are a lot of thoughts that any of us could have. You know, for us as clinicians even, who have been taught that we're not supposed to be deeply impacted by what's going on, we might even be having thoughts like, I should be handling this better. Well, that's a thought that will lead to us feeling disempowered. Instead, we could have a different alternative thought, which could be, I'm doing the best that I can, or I'm feeling like most people feel right now. That can be normalizing and make us feel empowered and hopeful. These helpful thinking boxes or tables are created by the National Center for PTSD, which are listed there as well. Oops, excuse me. And then this is the psychological first aid app that I mentioned previously that can be shared with safety people. So in the last few minutes that I've got with you here, I want to focus on what we're talking about, again, with culturally specific suicide prevention. I've mentioned it a couple of times throughout this presentation, and I just want to kind of bring it all back together again. So culturally specific suicide prevention, I would suggest, starts out with assessing the culturally specific suicide risk factors. For example, we have found that while many suicide assessments will look for feelings of depression, in many Asian American communities, what you see, the feeling that precipitates a suicidal crisis actually happens to do with shame. And so if we're not also clued into this idea that there might be, we need to ask about experiences of shame, we might miss some of that suicide risk among certain populations. Or there might be things around, as I was saying earlier, bullying for LGBTQ youth, or survivor's guilt for veterans. So we want to think about the culturally specific risk factors for suicide. We also want to build upon the culturally specific strengths in informing history. So Imhotep, 2,000 years before Hippocrates lived, and Hippocrates is identified as the Greek, father of medicine. 2,000 years before that, this Egyptian man identified that we could use a scientific method to diagnose mental illness and treat mental illness. And that's an incredible history for people of color who oftentimes are told that mental health treatments and everything are created by white society. And there's actually a very, very rich history of communities of color who have been engaging in mental health care. We can also draw from our culturally specific forms of art and healing, like blues music or sweat lodges, as I mentioned before. Culturally specific suicide prevention also acknowledges that there's an association between systemic racism, sexism, homophobia, transphobia, and classism with elevated illnesses. And this is the weathering effect, as well as just being predisposed to illnesses based on the material realities of our lives that are informed by those isms. And also lack of access to mental health care, and that there's a pipeline to incarceration. As I shared before, that when, especially with Black community, when people who are in African American or Black communities have mental health symptoms that are seen in society, rather than getting help, they are oftentimes engaged by police, who they might end up on a pipeline into incarcerated facilities rather than getting into mental health care. And culturally specific suicide prevention provides supports to unlearn internalized stigma. So these are transformative healing, oftentimes through storytelling, can be very helpful. That is, people of color, LGBTQ folks, unlearning the stereotypes that they were taught about themselves that can be related to mental health challenges. And also, there's an advocacy to end systemic isms in service of public health, because we see that there's a connection between these isms and mental health and physical health challenges. There are a variety of resources that I've provided here, links to, that are related to Black suicide prevention. Very quickly, I want to point out that this is Jasmine Pierre. She has a personal lived experience with suicide, and she created this amazing app called the Safe Place app, which is specifically tailored to the mental health experiences of Black communities. For example, it talks about challenges when the church or when family members say that mental health challenges are not a part of the Black community. Or it also addresses police violence as another issue that can be related to mental health. There are a variety of resources here listed for veterans. The SAVE training is terrific for clinicians. If you've never worked with veterans and you don't work at the VA, you probably will work with a veteran or a veteran family at some point or another. This SAVE training is specifically about suicide prevention with veterans. All Veterans Affairs hospitals in this country have suicide prevention coordinators. If you're working with a veteran, they don't access the VA, you can still contact a suicide prevention coordinator. I mentioned the crisis line. Make the connection videos our first-person accounts by veterans of their own stories of recovery. Those are great places for veterans to go and to get hope while they're in a social distancing situation. Cover Me veteran gunskins, I think, are one of the most profound interventions for veterans, and a lot of veterans that I've worked with have really appreciated these. A veteran can go online to this website and upload an image of a family member or a pet or some reason that they have to stay alive, and they put this on their gun, and many people have said that that's very helpful. Social distance power, I think this is one of the most amazing things that I have seen created during COVID-19. This is a social media account on Facebook where a variety of Native American, First Nations peoples from the United States, from Canada, from, frankly, I think many parts of the world have gone to share traditional dance and singing, which are oftentimes a form of healing and prayer, but also to provide support to one another around people who have thoughts of suicide have reached out and said that they needed support. And I'm seeing hundreds to thousands of people giving support for the people who are experiencing suicidal ideation. I've also seen people who are announcing their anniversaries of sobriety and other things. And it's just an amazing space that I would highly recommend sharing with any Native American clients that you might have who you think might be connected to this space as a place that they might, you can ask them, have you ever gone to a powwow? Well, there's now this social distance powwow online. This is an incredible program that was created for Latina youth. They asked Latina youth if they would like to do a suicide prevention intervention. They said, yeah, but we don't want to just sit around and talk. And so what they did is they created a crafting group. And I thought this is a great example for any mental health staff on this call who might be working with a group of Latinas. You can do crafts through video platforms like Zoom together. Here are resources for LGBTQ community. For anyone who is part of our LGBT community, watch out. You can lose hours and hours and hours of your life going into this amazing website because you can search by different parts of our community, whether you're looking for videos by lesbians or gay people or transgender people who are talking about how it gets better, to hang in there, because oftentimes we do feel better as the years go on and our life situations change. Here are resources regarding middle-aged and older white men, and then resources regarding children, youth, and families. So the final reflection, congratulations you all, you made it to the end of a very long information-packed presentation. In the chat box, I would invite you to please share one action that you will take as a result of this workshop regarding suicide prevention over telehealth during the pandemic era. I see people saying using the valuable resources, watching the suggested YouTube videos, the apps, sharing the resources, wonderful. Exploring culturally specific resources, Black suicide prevention, outstanding. I am so glad to hear that some of these resources are resonating for you. So with that, I am going to ask my colleague Angela if she would please share just a few questions that we have time for at this point regarding that were placed into the questions box. And those questions that were asked that we don't have time to get to, I will go through all of them and we can send them out to group registrants afterwards.
Hi, Eliana, can you hear me?
I can. Thank you, yes. Angela.
Okay, perfect.
Yes.
There were so many wonderful questions on the chat. It was quite active, so I'm going to just take a couple of questions here. So one is, are there any tips, additional tips for means restriction when working with minors? I know you mentioned the difficulty with parents and some of the parents not supporting the safety plan in that aspect. Do you have anything additional to add to that?
So if I understand the question, so the question is about, I'm sorry, means restriction and parents. Can you, I wonder if you might be able to read the question as it was written?
Yes, it says, are there tips for means restrictions when working with minors, particularly in the schools?
Okay, means restriction in the schools. Thank you. That's an excellent question. And I would say that means restriction at school, I would think that it would probably be really important to look at, well, what are the policies in place regarding what students can bring to school with them in the first place? And I think that for school-aged children, absolutely, as Angela was suggesting, communicating with parents or care providers with whom the child lives or spends time with, what means restriction needs to be put in place in the home or in the community. And one of the things that we're doing with the PSMHTTC, the Pacific Southwest MHTTC, is we're actually doing a series of trainings on suicide prevention. And I have a feeling that we're going to probably want to talk about doing a suicide prevention specifically for school mental health, where we might be able to get into the specifics a little bit more.
Okay, thank you. One other question would be, what are your thoughts about the CAMS framework, which is the Collaborative Assessment and Management of Suicidality?
CAMS has been found very effective based on research and is one of these evidence-based practices that can be very helpful in a variety of different contexts. CAMS is about a systematic approach to suicide prevention, essentially, that is looking at suicide prevention from a multi-layer, multifactorial perspective.
Last question, what is the best route to be certified as a suicidologist or someone who's new into the field? What is the best way to get additional training on suicide assessment?
Okay, so I'm hearing a couple of questions there. One is, what is the best way to get training on suicide assessments? And then another kind of larger training, question, which is about becoming a suicidologist. So I'm going to leave the question about becoming a suicidologist because I don't know, I'm a licensed clinical social worker. I know that suicidology is a robust field of study. But I think the question that is within my scope to kind of talk about today is how to get additional training on suicide assessments. So if you go to the links that I provided in the slides, there are a number of training opportunities for both the CSSRS and the ASQ online on the websites. And they involve everything from webinars to watching demonstrations of the assessment in practice to fact sheets and handouts and kind of decisional trees.
Do you want one more question?
I think that's all we can do for right now. Okay. I am so appreciative, Angela, that you read those questions to us, and I will definitely get into all the questions that people posted. I really appreciate you having taken time today to be part of this presentation. And again, I just really would appreciate if you would take the time to complete our questions, which will come up at the end of this, about what was useful and how this could be improved. If you missed any of our previous webinars, you can watch them online. They're all recorded and available online. And a certificate of completion will automatically be emailed to all online participants. If you joined by the phone only, please email Joanne Oshel to report your participation. And if you'd like CEs, you may request them by completing the survey. And you can email Carrie DeSell at pacificsouthwest@mhttcnetwork.org. And again, thank you so much for attending. But please do complete our survey. Thank you so much.